Coming up.
Realistically, if all we're going to do is give people the substance they're seeking, we're talking about palliative care because there's no other treatment for you as someone who uses drugs. You know, over here, what we would suggest is people do need comprehensive care. Absolutely they do. Housing, withdrawal management, all of those things. But we're talking also about supporting them while they're doing it. You know, and I guess the question is, you know, why would we use the so-called safer supply method when we know we have other alternatives like Suboxone? Why, you know, I guess, how could you argue against that?
Mr. Patel, what does primum non nocere mean in the Hippocratic Oath?
Do no harm.
First, do no harm. Is that correct?
Correct.
How do you square that as a physician providing safe supply?
You don't have studies that prove that there isn't diversion, but you're saying diversion isn't a problem. How can both statements be true at the same time?
Like and subscribe.
Oh, thanks very much, Chair, and thanks, Dr. Patel, for being here. You know, I guess one of the things that I would take to object to and find difficult is, you know, when you talk about treating diabetics as a physician, you're talking about treating one patient. What we're talking about here is how did a population respond to some measures put in place by this coalition government, which has then allowed more and more people to access those short-acting narcotics, which you find so objectionable, and I believe you should. So maybe you could comment a bit on that, because our job here is not to look after one patient at a time, as yours is. Our job is to try to help an entire country, which is in a terrible crisis.
Yeah, absolutely. I take objection to the fact that I only look after one patient. It's true, I look after one patient at a time, but there's a cohort of patients that I manage collectively at Inner City Health. It's not just one patient, and all of their well-being is actually important to me. And therefore, the treatment approach that I use is really not that different from the infrastructure of diabetes. There's a community of patients who have diabetes. They have home care, they have foot care, they have regular clinic visits. There's an entire infrastructure we have collectively put in place, society, put in place to help manage them because we view that as an important problem. I think we should take the same approach to substance drug use because it is not a single patient issue. It's not a single entity. It's not an acute problem. It's a chronic problem.
Through you, Chair, and thanks for that, Dr. Pell. I mean, certainly from this side, that's not something that we're arguing because realistically, if all we're going to do is give people the substance they're seeking, we're talking about palliative care because there's no other treatment for you as someone who uses drugs. You know, over here, what we would suggest is people do need comprehensive care. Absolutely they do. Housing, withdrawal management, all of those things. But we're talking also about supporting them while they're doing it. You know, and I guess the question is, you know, why would we use the so-called safer supply method when we know we have other alternatives like Suboxone? Why, you know, I guess, how could you argue against that? That's my question. I don't know if you are arguing against it. That's my question. Are you arguing against using that?
No. So in fact, I do use Suboxone for some of the patients that I actually look after downtown, but that's a patient autonomy issue, right? A lot of people don't want to be on Suboxone because they don't actually necessarily want to stop their entire drug use. I don't want to stop taking a single malt shot of whiskey on a Saturday night, but I want to be able to use it responsibly. So as long as they have capacity and they turn down Suboxone, I can't enforce that treatment on them. I understand the value of Suboxone because there are some patients who actually take it and do well on it. So if the goal is to get them completely off any opioid, whatever substance they're using, and the patient actually wants to do that, then I agree with you. We should look at other alternatives than safe supply. But often, the only way to get the patients to trust us and us as an infrastructure of people at the front lines looking after patients is to start them off on Dilaudid, to get them into the fold, to get them to trust us, because you have to remember, and again, as a physician, you know that building trust is crucial. And a lot of these patients who end up on the street, have substance use disorders, have gone through horrible life journeys where the people they wanted to trust let them down. And so for us to develop that trust takes time. I wish I could start everybody on Suboxone and see how they do. But the reality is I can't because of the individual situation.
I guess the only other argument, Dr. Patel, is really related to the fact that you and I both know that the opioid crisis was largely fueled by OxyContin, prescribed by physicians. And I guess what I would suggest to you, and just for the record, he nodded in the affirmative to that statement. My question would be, is how could we then suggest that flooding the market with more and more opioids for people to use at their will is going to be a benefit? To me, that's counterintuitive. It really becomes nonsensical to say, we got into this problem, which we agree on, based on the fact that there was an oversupply of readily available, high-potent, short or long-acting opioids, and now we're going to get out of it by giving people more and more opioids. That seems counterintuitive to me. I agree with you that we need to create spaces where we have relationships with people and things like that, but just saying, here, take whatever you want, that really doesn't seem to be sensible to me.
So I would disagree with the statement you're making, take whatever you want. That's actually not the case. That's a gross oversimplification. I think you know that. The reason for safer supply is to try and build trust while keeping the patient alive. If they're dead, who cares? Why use Suboxone? Why worry about dillies? They're dead. The problem's gone. But we're human. We try not to kill people if we can actually avoid it through a variety of different societal policies. This is no different than that policy. The goal of safer supply, I'll say it again, is to keep people alive so that we can actually get them the help they actually need. There's no other way around it. If we take away safer supply, people will die. You're going to have a bigger problem on your hands.
Thank you.
And that's the issue.
What recommendation you are giving to this committee to what led them for their recovery?
Thank you for the question. Appreciate it. The fundamental thing, I guess, I would request the committee to remember is that substance use disorder is a complex, chronic, wicked problem. There are lots of different things that have to be in place in order for us to manage it. You've had a question about homelessness. It's a crucially important thing, along with the other social determinants of health. The medical and mental health that we provide at Inner City Health is really one very, very small piece of the puzzle. All of the other things are crucially important. If you have a home, the reason you benefit from having a home, whether it's a small apartment or a house, is you have personhood. When you have personhood, you have a purpose. When you have a purpose, you're motivated to change. If you're living on the street, you feel, I would feel, I don't know how they feel, I can only imagine how my patients feel, but I would feel like I don't count. Nobody cares. Because if they did, why would they let me live on the street? And so the social determinants of health, I will argue, are going to be far more important for how we manage this problem going forward than safer supply, Suboxone, whatever it is that you want to put out there in terms of medical treatment. They are going to pale in comparison to what we do about the social determinants of health.
We're hearing about, for-profit mental health in the United States and that it's skyrocketing. Can you talk about the dangers that we could be heading when we go to for-profit care?
So this is something that I struggle with because in terms of the for-profit substance use care, provided that they're evidence-based, evidence-focused, it does provide an easy route for individuals to access, provided they have the means to access those services. So I don't necessarily think it's a bad thing, but from an equity perspective, it does not provide equity to the greater population. One of the things that Alberta has done, if I may, is that they have increased capacity for treatment supports. I think they're moving towards standardizing it, and I haven't seen that as of yet. But many of them do provide medication-assisted treatments. And last but not least, they are providing a bit more rigor around their programming. And so that is something that they are doing, but it's not necessarily ubiquitous throughout, and it needs to be better mandated, better standardized.
Thank you, Dr.
In my opinion.
Thank you. Mr. Doherty, please, for 5 minutes.
It's live. There we go. Mr. Patel, do you have evidence that safe supply isn't being trafficked or diverted to schoolyards?
I don't know how you would actually do that study because the safe supply drugs are not tagged, so there's no way of anybody knowing that a dilly bought by a school kid would come from a pharmacy
Traceability
or
on
not.
safe supply?
Sorry, couldn't hear you.
Would you support traceability measures on so-called safe supply?
No,
Why is that?
because it's a sinister entity. You're basically trying to govern somebody's autonomy. We don't do that for anything else. Why would we do it here?
Mr. Patel, has your program received federal funding through SUA? Okay. Annually?
I think it's a 3-year program right now, renewed on a 3-year basis.
I take offense to Mr. John's comment to you regarding the politicization of a safe supply and the opioid crisis. I do agree with you that we are seeing more of it. It is more evident. It is out in the open. Our communities, well, they look like war zones. And I thank you for telling this committee that, what the high is like for those that are addicted to these drugs, that they're chasing it all the time, continually chasing that high. It's why first responders say that if they attend somebody that is overdosed or OD'd and they administer naloxone or what have you, the person that comes out of that or is rescued is very angry. Oftentimes they come up swinging. But I would offer to you this, that why politicians and why it's become such a hot button topic is that since 2016, over 47,000 Canadians have lost their lives to overdose. We continue to spend a lot of money on programs, but we're failing Canadians. And that is why it is a hot button topic. We don't disagree with you and that more services should be there. At least on this side, we're saying we should do everything in our power to get people the help that they need. I think that is part of the testimony that you provided earlier on. Mr. Patel, what does primum non nocere mean in the Hippocratic Oath?
Do no harm.
First, do no harm. Is that correct?
Correct.
How do you square that as a physician providing safe supply to those that are addicted to drugs rather than trying to get them into help?
If I don't give them safe supply, they're going to die. Game's over.
Have you ever asked somebody on the street why or how they feel about living on the street? Because you said earlier on that you haven't asked that.
I have asked. Nobody actually aspires to live on the street. Nobody actually aspires to use drugs. It's a coping strategy.
Strategy for what?
All the trauma they've gone through in their life. For some people, they've lost a home because of interest rates, inflation. Other people have lost jobs. They end up on the street because there's no other place to go.
Or PTSD, struggling with PTSD, moral injury. I think Dr. Monty mentioned brain injuries as well, too. We see a lot of people that are struggling with traumatic brain injuries that end up on the streets, what have you. In my province, overdose is the leading cause of death for children aged 10 to 18. Were you aware of that?
I'm sure the statistics are correct, but no, I'm not.
One of the families that recently had a daughter that lost her life, their daughter was 13, just turned 13, living in a homeless encampment. You mentioned about autonomy, patient autonomy. Well, this family tried repeatedly to get their daughter, who was struggling with addiction, suicidal into treatment, and was told by the health authority and those that were there, if she wants to kill herself, that's her choice. 13 years of age, just turned 13 years of age. I wonder how you feel about that.
I think the experience that her and her family went through was absolutely horrible and unbecoming of a healthcare system.
Thank you, Dr. Patel.
Primum non nocere, first do no harm. Do you think that would be an appropriate motto for politicians as well? Dr. Patel?
Yes, it should be.
You talked about the conundrum of supervised consumption really being designed around longer-acting drugs, principally heroin, and now you mentioned that people often don't even have time to get into the facility because of the use of short-acting drugs. Can you talk a bit about that mismatch and what we need to do? Is it just, should we be actually putting more resources into safe consumption to make it that much more accessible, or is there a bit of a mismatch between the short-acting drugs and safe and supervised consumption facilities?
Yeah, it's an excellent question. Given that the actual drugs on the street are no longer the classic French Connection heroin, yes, first of all, I would argue that we need either extended hours of safe consumption sites or more, so that we can get people off the street where they can use safely and we can have eyes on them to attend to all the other healthcare problems that they actually need. I think also the way people are using drugs now on the street, as people who use drugs age, they have less and less veins in which to inject into. And so they're doing different things with the drugs they have. They either take them orally, which doesn't give them the same high, so they have to take more, or they're smoking or inhaling it, which is extremely rapid in onset. And that avoids going into a safe consumption site to find a vein to inject. And so as people are growing older, in their lives and using drugs because of all the other things that are influencing them, they're losing veins, so they're changing the way they actually use drugs. And that is actually problematic because they're smoking their fentanyl, they're smoking their crystal meth, they're smoking their crack on the street, whereas I can't bring them into a safe consumption site because of the laws around where you can and can't smoke, particularly indoors. So just like smokers at a bar, you can't smoke at a bar in a restaurant, so you go outside. Well, that's exactly the same thing that's happening. So
will closing supervised consumption sites actually lead to higher visibility of drug use and more encounters on the street?
My short answer is yes, because of the types of drugs and the way people are using them now.
Dr. Patel, you've raised the issue of how you don't have studies that prove that there isn't diversion, but you're saying diversion isn't a problem. How can both statements be true at the same time?
So it goes fundamentally down to why people divert. So people will divert predominantly because they don't have a place to stay, so they need a place to stay, they'll divert their drugs. They don't have food, they don't have shelter, they don't have hygiene. So that's a fundamental reason for diversion. The people I look after are not going to Lisker High School and Rideau High School and selling drugs to high school kids. That's not valued.
But that's not just the only diversion, and this is one of the big pieces we've been hearing, and there are countless articles that have been written on Ottawa propers and the Ottawa inner city health of those blocks surrounding the so-called safe supply programs where drug dealers go, they exchange fentanyl for these drugs, and then those drug dealers go and take them to the high school student, flooding the streets with these dillies and allowing people to have these take-home is creating chaos. Sandy Hill is not a safe place to walk. And I'm very curious how you can say that your clinic and diversion has nothing to do with the lack of safety in that community.
So I fundamentally disagree with the inference that safe supply is the primary driver of chaos, as you call it, on the street. The fundamental driver of chaos on the street is the type of drugs that are actually available on the street. Treating a fentanyl and crystal meth problem with Dilaudid is like treating my arm that's being chopped off in a car accident with pediatric Tylenol. It's a fundamental mismatch. If we want to improve what we're doing, then there are different ways to do it. Fentanyl, actually providing fentanyl to patients would be, the kinds of people likely, would be one alternative. So if you have that, then you're going to see what
Dr.
you call
Patel,
chaos.
You are an advocate of having fentanyl available in a so-called safe supply program.
I am an advocate of doing that because it'll save lives.
So my next question is, I see that yesterday, in fact, you guys had an extension to your guys' clinic for an additional 3 years as per Health Canada. What consultation and communication have you had with the surrounding community in regards to the clinic's operation?
I'm not sure I understand the question. Forgive me.
Well, oftentimes there's a communication with your neighbors when you're operating something. There's increased crime. There's tons of reports of increased crime. Have you had any conversations? Was there any requirement by Health Canada to have community consultation to make sure that public safety was being maintained?
There's no requirement from Health Canada, but we fundamentally, as an operating infrastructure, do consult with all of our community partners across the lower town and across the different shelters that we have across the city.
Okay, so Health Canada does not require you to have any consultation with community or take into account the public safety, the larger public safety risks when operating?
Not on a formal basis that requires any particular reporting that I have to do or my CEO has to do back to Health Canada.
That's incredibly troubling as we see so much crime happening in the very few blocks around your guys' clinic, and to know that Health Canada basically just gave you another rubber stamp to continue to operate for another 3 years without taking any additional measures into place to ensure that diversion isn't happening, to ensure that public safety is being put front and center so that kids aren't being put at risk. I really do not understand how Health Canada is doing its job and not doing those kinds of things. All right. So my last question, I guess, is to Dr. Ghosh. Are you familiar with recovery-oriented housing solutions like Oxford House?
I am, yes.
Do you believe that recovery-oriented housing solutions similar to Oxford House are a good model to get people housed and break the cycle of addiction?
I do. So Oxford House is essentially a high level of supportive housing. And it is an equity-based supportive housing facility as well, meaning that it is public, paid for by the government of Alberta, which is one of the points I wanted to make earlier, was that the government of Alberta has provided access to these services for free. So the key to Oxford House is that it helps build community. They are long-term treatment facilities in the sense that it's not just 3 weeks that people spend there, it's not just 6 weeks people spend there, but they can spend a long time in these facilities. And we know that the longer they spend in these treatment facilities, the better their overall outcomes will be post-discharge from these services. The other benefit to Oxford House is that they also provide transition services back into the community, which we also know is another key evidence-based idea that provides increased support for the clients and now has better outcomes as well in terms of recovery and cessation of substance use and decreased relapse.
Thank you, Dr.
So
Ghosh.
Oxford House is a... Sure.
Thank you.